Welcome to this explainer. We're going to run through a rapid-fire trauma assessment protocol, tackling high-stakes clinical scenarios to lock in those life-saving surgery principles. Here is our agenda for today. 1. Neck and chest trauma. 2. Life-threatening cardiac injuries. 3. Abdominal damage control. And 4. Pelvic and urogenital trauma.
Section 1. Neck and chest trauma.
All right, first question. A 28-year-old male arrives with a stab wound at the base of the neck. What is the most dreadful sign requiring immediate surgery? Is it A, subcutaneous emphysema, B, hoarseness, C, an expanding hematoma, D, dysphonia, or E, dysphagia?
The correct answer is C, an expanding hematoma. The reason this is absolutely critical is that it rapidly compresses the airway and major vessels, causing imminent asphyxia. For your exams, remember this pearl. An expanding hematoma is an absolute indication for immediate exploration. You don't wait on this.
To understand this anatomically, let's look at the neck zones mapped out for trauma. Zone I extends from the clavicle up to the cricoid. Zone 2 goes from the cricoid to the angle of the mandible, and Zone 3 stretches from the mandible right up to the skull base.
Next question. Which of the following is the correct management of a sucking chest wound? A, a one-sided dressing. B, a two-sided dressing. C, a three-sided dressing only. D, a three-sided occlusive dressing followed by chest intubation. Or E, irrigation.
You're going to want D, a three-sided occlusive dressing followed by chest intubation. And whatever you do, do not use a four-sided dressing. Sealing all four sides traps the air inside, which quickly converts the injury into a deadly tension pneumothorax. Section 2. Life-threatening cardiac injuries. Okay, check this scenario out. We have hypotension, JVD, and muffled heart sounds after a road traffic accident. What is the diagnosis here? A, tension pneumothorax. B, open pneumothorax. C, massive hemothorax. D, cardiac tamponade. Or E, sternum fracture.
The diagnosis is D, cardiac tamponade. This presentation is the classic Beck's triad. It's a clinical diagnostic triad made up of hypotension, jugular venous distension, and muffled heart sounds. Seeing all three indicates obstructive shock specifically due to cardiac tamponade.
Let's move on. Which patient needs an ER thoracotomy? A, major blunt trauma with 15 minutes of CPR. B, a comatose patient. C, a penetrating stab to the left parasternal area with 10 minutes of CPR. D, penetrating trauma with 20 minutes of CPR. Or E, none of the above.
The correct choice is C, the penetrating stab to the left parasternal area with 10 minutes of CPR. Why? Because this patient is actually salvageable if an immediate thoracotomy is performed. The exam pearl here is that your primary goal is the relief of tamponade and cardiac repair, typically done via a left anterolateral approach.
Section 3. Abdominal damage control.
What is the best initial step for hemostasis in an unstable patient with a grade 4 liver injury? Is it A, the Pringle maneuver, B, packing, C, mattress sutures, D, vessel ligation, or E, electrocautery?
The right move right out of the gate is B, packing. Look at the damage control sequence for liver trauma. Step 1 is always packing and compression. Step 2 is the Pringle maneuver, but only if the bleeding continues. And Step 3 is the definitive repair, which you only do later once the patient is stabilized.
Next question. A vitally stable patient presents with blunt left lower chest trauma. What is the next best step? A, observation. B, a CT of the abdomen and pelvis with contrast. C, laparotomy. D, an X-ray. Or E, laparoscopy.
Since the patient is stable, the correct answer is B, a CT of the abdomen and pelvis with contrast. Here is the crucial comparison to keep in mind. For stable trauma management, a CT scan with IV contrast is your gold standard for mapping the injury. However, for unstable trauma management, you skip the CT, use a FAST or DPL, and go straight to laparotomy.
Section 4. Pelvic and urogenital trauma. Here's the scenario. An unstable patient with a pelvic fracture has a binder applied and a negative FAST scan. After an external fixator is placed, they deteriorate. What's your next step? A, angioembolization. B, resuscitation only. C, iliac artery ligation. D, pelvic packing. Or E, laparotomy.
The answer is D, pelvic packing.
The reason for this is that 85% of pelvic bleeding is venous, primarily coming from the presacral plexus. You control that massive venous bleeding by packing the prevesical space.
Next one. What is the most commonly injured urethral part in a pelvic fracture? A. Bulbar. B. Membranous. C. Prostatic. D. Penile. Or E. Retrobulbar. That would be B, the membranous urethra. The mechanism of injury is a shearing force right at the bulbomembranous junction. A couple of massive exam pearls here. Always look for blood at the meatus and a high-riding prostate. And absolutely never insert a catheter blindly if you suspect this injury.
Let's wrap up with this thought. In the trauma bay, adhering to the damage control philosophy and making split-second clinical decisions is the ultimate difference between life and death. So when those double doors fly open and the pressure is on, will you be ready to make the call?